Welcome to Live Your Legacy podcast. Thank you for listening.
Welcome back to the Live Your Legacy podcast here at Legacy Physical Therapy and Wellness. I'm your host, Jeremy Gavanovitz, and with me is CB as well, my boss. Today we're excited to introduce a good friend of ours and one of the best in the field actually as well, Dr. Zahab Ahsan. He's a board certified orthopedic surgeon specializing in sports medicine as well. Doc's performed hundreds of different surgeries and operations and everything throughout his career, helping people get back to what they want to do. Everyone from weekend warrior to the typical patient and athletes as well. So today we're going to break down ACL Reconstruction, the whole process from beginning to end, from the surgeon's perspective. So it's a pretty cool episode that we have for you guys today. And so Doc's going to discuss how the surgery is performed, what patients can expect before and after surgery, and then how physical therapy plays a role in their recovery. So before we jump in though, we're going to have a question of the day, and stick around until the end of the pod so you can get the answer. So today's question is, what is the primary function of the ACL? And with that, let's get into the episode. So first off, thanks for being here.
Yeah.
Doc, CB and I are really grateful that you're here, and we think this is going to be a pretty informative episode, so we're looking forward to it. Can you share a bit about your background, like education, kind of what drew you to medicine, and your interests and how they developed?
Absolutely. Yeah, thanks again for having me. Looking forward to this conversation and the ability to shed some light on all the thoughts I have on the intercruciate ligament or the ACL and how treatment has evolved over time, and I guess what got me to where I am here today. And so my background, I grew up in a small town of West Lafayette, Indiana, about 2 hours south of Chicago, home of Purdue University. And, growing up, my main two sports were football and wrestling. And had the opportunity to really collaborate with our team physician, as well as kind of work a little bit and see kind of the realm from the other side as an injured athlete, and experience what care is like for our sports medicine colleagues and really what's going on in that realm. But primarily I saw it really as a journey of blending my personal passions and my professional passions into one. And my dad was a physician, so very early on, I had the opportunity to see what a physician's life was like, and the opportunity they had to make an impact in a daily life, in the lives of others on a daily basis. So I think that was really one of the things that kind of propelled my career into medicine. And from there, growing up in the hometown of Purdue University, I wanted to stick around and really take advantage of that time frame of staying close to home, but taking advantage of a great university right in our backyard. So I studied engineering at Purdue, which is known well for being an engineering school, in particular biomedical engineering, which really kind of introduced me to some of the intangibles of mechanics and understanding some of the principles from a physics standpoint that really helped me in my orthopedic education as I progressed. And so staying in state, I attended Indiana University School of Medicine. That was in Indianapolis primarily. And having spent most of my life in the Midwest in Indiana, I decided, okay, it's time to get outside the Midwest and explore something new. So I was fortunate to end up in University of Washington in Seattle for my residency in orthopedic surgery. And the focus in the residency program, which is a 5-year process, is really developing the fundamentals of orthopedic surgery and understanding, the principles of taking care of the musculoskeletal system. And so in those 5 years, we really developed a skill set to be a well-rounded orthopedic surgeon and treat kind of all kinds of musculoskeletal injuries, including spine and really the whole gamut of things. And then after those 5 years of residency, many of us choose to subspecialize in a specific discipline, and that's a 1-year accelerated process known as fellowship. And that fellowship I chose to pursue was in sports medicine and shoulder surgery. And I was fortunate to end up at the Hospital for Special Surgery in New York, which is one of the top orthopedic institutes, especially for sports medicine. In particular, in the last 15 years, they've been number one by US News and World Report for orthopedic surgery and sports medicine. So that was really kind of the pinnacle of my educational process, and I was very fortunate to end up there. And having completed that training, I was very fortunate to come back to the Midwest and be close to family and have the opportunity to practice in a great community.
That's great.
It's awesome.
That's great. Yeah, absolutely. So for listeners that might not be familiar, kind of transitioning to the topic of the pod right now, can you kind of briefly explain what the ACL is, its function, its job, and how important it really is for knee stability.
Yeah, absolutely. So the ACL stands for anterior cruciate ligament. The ligament in particular means that it connects bones to bones. So it connects the femur to the tibia. Anterior is really an anatomic reference in space, so it's towards the front, although it's kind of crossing through the knee, which is what cruciate means. So you have this ligament that's connecting two bones that's crossing through the knee. And where it's strategically positioned, it really allows for providing the stability for athletic movements. So that's cutting, changing direction, jumping, landing, a lot of the things we think about that propel us forward and allow us to perform at the highest level really depends on the function of the ACL. And along those lines, we see it being one of the highest percentage of injuries of the knee that are severe and significant. And that's just because when you're overloading in a certain manner or changing direction, that's the ligament that can see a lot of that load. And that's, our main topic here is I think one thing we talk about is prevention, but more importantly, treatment and getting people back on the field doing what they want to do.
Right. Sure. Yeah, of course. And in that vein, I mean, there's obviously the surgery and the reconstruction that you have to perform. So what are the main reasons or indications for where you would choose surgical reconstruction versus maybe like a more conservative management?
Absolutely. In my training, I'd say if we rewind the clock 10, 15 years, I think there was really more of a debate to this, where there was a certain subset of patients that were like, okay, maybe they don't need an ACL, what's going to happen in the long run? And over time, I think our perspective has really changed that, living without an ACL predisposes the knee to wear and tear, degenerative changes, progression of osteoarthritis, as well as it predisposes the individual that has the ACL deficiency to additional injury within the knee, whether it's the meniscus or some of the surrounding structures. And so, when 10, 15 years ago, we're really contributing to this topic and thinking about non-surgical management, I think a lot of that has really shifted to treating just about everybody that has that injury. Mm-hmm. Of course, I have patients that come into my office that, maybe are more sedentary, don't have significant activity goals, or maybe their health precludes them from undergoing a procedure and they're not interested in being active, or they're threatened by the thought of surgery. And those are the individuals we're really particular and try our best to be non-operative, whether that's completing a rehabilitation program or using a knee brace. But I think, modern ACL surgery techniques really allow us to restore the mechanics of the knee and do it in a safe and reliable fashion that almost, all or majority of the patients that we encounter are good candidates to proceed with that procedure.
Yeah, of course. Perfect. Yeah. If you, let's say a patient does need to have reconstructive surgery, take us through morning, before the operation itself, and then post-op, immediately, that day. If I were to come in for ACL, how would it go? How would it go in the OR? How would you address the patient before? Take us through a good day in the life of that.
Absolutely, yeah. I think there's a lot to talk about even before the OR day, but we'll
start here. Of course.
And I think, really planning and thinking about this procedure is really key, and I think we'll get into that a little bit more. But if you think about the day of surgery, typically for me, I see, I'll maybe use this in quotations, but I see ACL reconstruction as really the holy grail of sports medicine. So this is something that I really prioritize and hold in a very high regard. And those patients that come through our clinic and our practice that have this injury, they really get the most, utmost attention and really focus on details. So starting with that, the majority of our ACL reconstructions start first thing in the morning. Mm-hmm. And there are days that we do 4 or 5 in one day, and it's kind of a one after another. But again, it's one of those things where we have the team fresh and ready to go. And for a lot of people, that means you're arriving at the hospital or the surgery center around 5:30 in the morning. You haven't had anything to eat or drink from midnight the night before. We've actually instituted this Gatorade protocol, which was really familiarized by our anesthesia teams, that actually helps to reduce nausea, a little bit of hunger, and really helps make that process a little bit more straightforward. That really begins with taking one Gatorade about 8 hours before the procedure and another 4 hours before the procedure. So that actually helps people stay hydrated, helps minimize some of that hunger, and really prepares them for the day. Then they arrive. First step, checking in, kind of the simple things you do for anything. And then you'll meet a nurse, you'll get an IV. IV is an access to the blood system that allows to deliver IV medications, whether that's a pain medication or a kind of a relaxing or anxiety reducing medication. And you'll meet our anesthesiologist. Most, if not all, of our procedures for the knee or kind of more involved procedures undergo what we call a regional nerve block. That regional nerve block will provide anesthesia assistance, so it helps to numb up a certain distribution in the knee, which helps reduce the amount of medications that are required to be delivered to the patient at the time of anesthesia, which makes the whole process a little bit more well tolerated from a pain management standpoint as well as a side effect management standpoint. Post-operatively, that anesthesia nerve block typically lasts anywhere from 12 to 24 hours, sometimes beyond that. And that really, we'll talk about this a little bit later, but I think that's really valuable in getting people in for physical therapy in that first 24-hour period, because for many of them, that nerve block is still functional and it can really help them jumpstart some of their recovery. After that nerve block, they'll encounter myself. First kind of communication from our team. I'll kind of review the procedure, make sure that everything is set for post-operative care, including physical therapy, as well as if they have any questions at that time. Again, our goal is to really, one, answer those questions prior to surgery, set expectations, as well as provide literature and documentation to make sure everybody is really well prepared going into the procedure. So, our really discussion is, hey, on the day of surgery, what's happening? So when the patient and I first meet in the morning, one of the most important things that I will do is I will sign the extremity with a purple marking pen. That marking pen is not truly permanent, but it sustains being scrubbed with our scrub solutions, and it confirms the correct site for surgery. That's one of the most important things from a checklist standpoint of confirming safety and efficacy of our procedures as we go through the day. As everyone has two extremities, they have two arms, two legs, etc. And so getting it right is very, very important. From there, the patient will enter the operating room. When they enter the operating room, they'll potentially remember that initial few minutes of entering, and then they'll start the general anesthesia process for which they will not have any further recollection. And from there, really the next step is preparation of the limb. So the patient will be positioned first and in an optimal position. So when we talk about positioning, that's to allow the surgery to be executed well. So a lot of the techniques that we involve use technology. We have 2 monitors that allow us to use the scope to go and visualize the knee. We have those positioned in a strategic position that all of us can see the monitors, and we can be ergonomically situated around the patient to be able to safely execute efficiently. After the patient's in that position to access the knee reliably, we start to sterilize the leg. That sterilization is a 3-step process. First, we scrub the leg with a chlorhexidine solution, something that they have done 5 days prior as well. Then we use an alcohol solution, and then we use a sterile chlorhexidine solution, which stays on the limb from the hip all the way to the foot, and sterile drapes are applied. Then the surgery commences effectively. Surgery involves myself, a scrub nurse who's scrubbed into the team that's providing instruments and helps guide the next steps, physician assistant, Sensor Jacob, you guys know him well, and then surgical assistant, AJ Arenas. So we have a really kind of consistent and really well-prepared team. Each of our team members have more than 10 years of experience treating these types of injuries, preparing grafts, knowing each step in and out. And I think that really allows us to execute things very, very efficiently and reproducibly.
Yeah, perfect. Yeah, you mentioned the grafts a little bit too. So how do you determine what technique to use, types of grafts? Is it different for particular athletes or age groups? How do you go about that?
Yeah, I think that's a really, really profound question, and I'd say I've spent many years kind of contemplating and refining those techniques and thinking that through. So going through my training, I would say I had the opportunity to learn from and work with mentors over the course of 4 or 5 years that performed ACL surgeries for many, many years. So I'd say I've really distilled techniques from 5 to 10 individuals into one, kind of borrowing what I found was most efficacious and successful from each of them, and really kind of building and optimizing what I think is best in my own hands. And I think one of the most important questions that we have in that realm is graft selection. Where do we start? So as we had talked about the ACL, it's the ligament that connects bones to bones. When it's damaged, I often describe in the office that it's like a rope that gets shredded. So there's no stitching that together. We have to reconstruct that ACL. Reconstruction means that we replace it with a different type of tendon or ligament or some sort of soft tissue structure. That can either come from the patient, we call that autograft, or it can come from a cadaver, somebody that's passed away, which is allograft. The literature in the last 5 to 10 years has shown us that allograft has a 4 to 10 times higher risk of failure or re-injury And that has been evolving data. And so many of us, as I speak of orthopedic surgeons, have really shifted away from using allograft tissue for reconstructing ACLs. There's always the one-off examples where I think it's more practical, but in general, my preference is, especially focusing on our young active athletes and really that young term, I feel like continues to progress. I can say that there's people in their 50s and 60s that come in that I'd still see as active athletes. And I really treat them with the same principles that I would treat a 17-year-old football player in my office. And so autograft is king, right? So we have to take the patient's own tissue because that's going to reintegrate, that's going to revascularize, that's going to allow for a successful and timely rehabilitation and maturation of that graft. Maturation meaning that it really integrates and becomes their own and can sustain forces that we see in our contact and collision sports, for example. So of those, the three main most popular types of autograft are patellar tendon, which goes from the kneecap down to the tibial tubercle. We would take the central 1/3 of that patellar tendon with a piece of bone at each end and secure that with screws. There's quadriceps tendon. That would be the same thing as central strip of the distal quadriceps tendon. That can be taken with or without a single bone plug from the kneecap. And then there's hamstring tendon. We have 4 hamstring tendons. We would take 2 of them, semitendinosus and gracilis, and reconstruct the ACL. The hamstring tendon graft is primarily a soft tissue graft, meaning that it's secured with stitches and what we call suspensory fixation. So in my hands and my kind of understanding, I see that as a slightly inferior fixation to screw fixation, which is what we do for patellar tendon grafts. So my thought process there is that the most reliable grafts that I see from time zero fixation, meaning when they leave the operating room, that I'm not worried about that knee moving even a millimeter, is the patellar tendon graft. And that I would say the vast majority of my athletes and ACL reconstructions receive that. The quad graft is getting more and more popularity and a lot of fixation techniques are improving and people are using that often. I see that as a great revision graft. I see it as a good graft in individuals that have patellar tendinopathy or some areas that the patellar tendon is not quite healthy. But it's not my primary graft as of yet. I have some patients that come in and like, hey, my friend had a quad. Can I get a quad as well? And I think that's very, very reasonable. I think they've done very well. I find their rehab to be a little bit more challenging, and I'd love to hear what your guys' perspective on that is as well. But I find that the extensor mechanism, which is the ability to straighten the knee, which is very, very important in rehabilitation and knee stability, gets impacted just a little bit more than the patellar tendon. And so it's just a little bit more work, maybe a little bit more stiffness that can occur in that time frame. And just subtle things that we're kind of choosing in between here. The hamstring graft has been shown to have a little bit higher risk of re-injury. I think that's really attributed to, you have 2 strands of soft tissue. There's multiple preparation techniques, meaning multiple ways that you can put that into the knee and secure it. I typically use a quadruple technique. So that's effectively folding it in 4. So you have 2 times 4 is 8 strands. It's a very, very strong graft. That takes a lot of really fastidious focus on details and it takes time. And I'm blessed to have 2 assistants that can prepare it very, very well. And so I still trust that graft. I tend to use that in probably, some of my patients that are age 35 plus that are a little bit more relaxed from their goal standpoint with regards to activity and contact sports. But it's still something that I find to be perhaps a little bit slightly easier graft, less pain post-operatively and a little bit smoother rehab. And there's some subtleties, but I think the takeaway is that having a skill set that can use all of the grafts that are available and being able to implement them and personalize them, I think is very, very important. And that's one of the things that I really prioritize.
Yeah, that's awesome. Is there ever a time when you kind of get into the operation and you have a plan to maybe use a particular graft for a patient, and then you might have to change if you get into see the anatomy? Is there ever a time where you have to change because it doesn't look right or it doesn't seem as
so
neat as you thought?
From our perspective, we're very fortunate that our MRI technology is very, very high quality. That allows us to visualize those structures very well prior to surgery. So I can not only see the quality of a patient's patellar tendon, I can measure it. I know how wide it is, how long it is, have a sense of their bone surrounding it. So all those things go into some of my preoperative planning, but can really guide me and prepare me for choosing the right graft, so that by the time we get to the operating room, we're really in this position of executing our plan, and we put in all the time of planning and really thinking about what to do prior. and that makes things a little bit more streamlined.
Yeah, awesome. Very cool.
Yeah. To kind of piggyback off on it, with your graft selection, when you choose like the auto and you do patella or hamstring, have you seen anything like 1 or 2 years out where patients may have more complaints on one graft versus the other? Sometimes on the physical therapy side of things, if we see someone that maybe have ACL surgery a couple years back and they might complain this anterior knee pain or this residual hamstring weakness, and maybe a hamstring graft or things like that. So on your end, I just want to kind of see from your perspective on that.
Yeah. So I think those are two very important points to think about. Anterior knee pain, I think, is a really great discussion point here. In my education as a resident, even a little bit as a fellow, I was educated that, hey, these patellar tendon grafts can have anterior knee pain. I had some very confident attendings, which I didn't necessarily 100% believe, but they told me, hey, it doesn't exist, right?
Yeah.
If you do this procedure right, patients are not going to have anterior knee pain. And I'm in my 6th year now. I've done well over 300 ACLs, and I would say that I have not had a patient complain to me of anterior knee pain that's persisting beyond the first phase of recovery. I know you guys can comment on that as well. Maybe they're not fully being transparent, but I don't feel like anterior knee pain is really a concern, patellar tendon surgery. And part of that is because we're very, very detail oriented about the bone grafting technique. So that bone that's being harvested from the patella is effectively being filled by bone. So we're rearranging some bone, but we're making sure that the patient doesn't have any bone defects or deficits at the end of the procedure. And that, I feel like, has a lot to do with why patients do so well. And management of the remaining tendon. So we take a small strip of the central aspect of the patellar tendon, but then I take a lot of time to reapproximate and repair the remaining aspects of that tendon so that it really looks native. I comment on this during the surgery sometimes. It's like we like to leave it the way we found it. And I think that really has a lot to do with how patients recover and rehabilitate post-operatively and don't have any residual pain or discomfort. Your second question was really more about hamstring weakness. This is something I have observed. And so when I make the decision and determination of using a hamstring graft, I think it's very important to really assess the patient preoperatively, right? So some people are more quad and extensor dominant, some people are more hamstring dominant. I feel that there are certain people that are very robustly built that you can take a hamstring from them, they're not going to feel it. Whereas there's others that really may feel that deficit. I think there is a clinical gestalt or decision making that comes with experience, and I have patients that have a year later and like, you know what, this hamstring's not as strong. And I have others that are like, man, I don't feel like you took anything. So I think there is some subtlety there, and it goes back to personalizing that graft selection process and really making it ideal for the person that we're doing surgery for.
Yeah, that's great. And it just shows like obviously is variance and knowing that not two knees are alike, right? And so that's it's a great to kind of note that. Getting back into like the surgical procedure as well. Often as physical therapists, when we're working with some of our patients, and our big focus is trying to get extension. We want to get that knee to get straight like right away. Sometimes it comes a little slower depending on multiple factors that can be provided. One theory that I have heard from the surgical side of things is sometimes if you have the graft that's too far anterior from the anatomical spot where it naturally is. Have you come across that, or have you? What can you speak on that piece a little bit more?
Absolutely.
Yeah.
So that goes into some of the nitty gritty, so to speak, or the details and execution of the procedure.
Sure.
Right? So the ACL travels from the tibia into the femur. It has an area known as the footprint, where it attaches on the femur and where it attaches on the tibia. Our objective and our goal is to execute that new graft, that new ACL that we're putting in the knee, and put it as anatomic as possible, meaning matching those footprints as naturally like it was prior to the injury. And I think doing that over years with the same team has really helped us elevate that process and making sure that it's reliable and reproducible every time, because I have multiple sets of eyes on this, and my assistants are not afraid to speak up and be like, let's move that a millimeter, let's do something a little bit different. And I think that really helps us have a standard that sets it, perfection. And we do check, right? So we check to make sure that there's no extension impingement, which would be the process that the graft is slightly out of place. And so by reliably getting that graft in the appropriate anatomic position for the patient helps us really not have to worry about having any impingement or inability to fully straighten the knee.
Yeah, that's awesome. And I think it's I think for definitely all the listeners, and I think it's so important it matters who you go to, right? It matters who you see. These are some good questions that you could ask on your appointment when you're scheduling that surgery. Of consistency with the team is so key for all avenues. But I think that's great that you shared that. So, so now obviously you've done the surgery. Well, back up. You have a confirmed ACL tear. You have a confirmed ACL tear. Patient walks in. You're talking surgery now with them. So, what's that conversation like from a pre-op standpoint when that patient with the confirmed ACL tear comes in already and you're preparing for surgery?
Absolutely. So one of the, I say, most rewarding conversations that we face in the office is this preoperative ACL conversation. I think over the years, our technology has advanced to the point where people get the MRI, they get the reports, they have this emotional understanding, and they know coming into that visit that they have a torn ACL. Very rare is it that I see a patient that doesn't know and I'm telling them that their ACL is torn. Obviously, I see them at the initial visit, I have a suspicion, I set an expectation like, hey, my concern is for an ACL tear, but then they go and get the MRI done, they see the results, they see the reports, so they know coming in. So at this point, more often than not, we're with an athlete and their parents or a care partner, a family member. And really, for me, it's about education. And it really starts, I have a model in the room. I take that a model which has three-dimensional geometry and really explains the anatomy of the knee and explains to them, hey, this is the ACL. This is what it does. It provides rotational and front-to-back stability of the knee. I correlate that with the MRI. I show them exactly what is injured and what it looks like, and then the surrounding structures, whether there's a meniscal injury, whether there's a collateral ligament injury, some of the ligaments on the side of the knee. And then we talk about next steps and some of these things about graft selection. Hey, what are we going to do? And for me, I think the most important thing there is, one, establishing the diagnosis. They have an understanding of what it is. Establishing a treatment plan, like, hey, this is something we can fix and we can get you back or better than you ever were. And having that conviction with the patient that this is what we can do, and then laying out a game plan, like this is what it's going to take, right?
Sure.
I think that's where I find it to be really, really valuable. And I think the element from there is, we talk about, hey, you're going to get a knee brace. That's going to be immediately after surgery. We're going to try to wean that off as soon as we can. But then it really ties into physical therapy. And so all of my patients go for something called prehab or rehabilitation prior to surgery. And I think that really sets the tone. And I was thinking about this podcast. I came across this term in my mind, and I was like, I think it's about psychological acclimation, right? So you're getting them in this environment of like, hey, you have an ACL tear, you haven't even had surgery yet, but you are with the team that you're going to be spending a lot of time with, and you want to be psychologically ready for what's going to be coming ahead. And I think that personality match, understanding what it's like to be able to connect with someone that, hey, you're going to have surgery, things are going to get a little bit tougher than they are now, and we're going to be there with you. And having that trust as opposed to being immediately after surgery, I think that carries a lot of weight. So patients get acclimated to what's coming psychologically. And I think that sets this expectation for success. And so, I think one of the things that's really important there is that prehab, my goals are that just about everybody, whether there's a meniscus tear or not, should be able to walk without crutches, should be able to have full or close to full range of motion of the knee, and should have their effusion or swelling around the knee be controlled. It may not be the exact same as the other side, but it can be very, very close. And the quadriceps muscle and some of the muscles around the knee, we would like those to be firing or functioning close to their baseline level of function going into the surgery.
Sure.
And that's kind of the checklist in my mind that really sets them up for success. I often tell people, well, you want to be going into surgery as strong as possible so you can come out of surgery as strong as possible and quote unquote hit the ground running or at least walking.
Yeah. I mean, first, I'm gonna have to steal that term. I love it, and I think that's what we experience on the physical therapy side of things too. When patients come in for their pre-op PT, it's obviously establishing those things we talked about, like trying to get as much extension as you can, reduce swelling as much as you can, get their gait back to where they're mostly functional, right? So all those things, but mostly is building that rapport already, right? Building that rapport, making sure that they're comfortable, they're in a good spot. Layer in some of the expectations that you already mentioned as well too, I think is key. We all have short-term memory when it comes down to like how things go. But I think that's really cool that you kind of labeled it that way. So definitely putting that in my basket here. So obviously pre-op. Pre-op is extremely important. I love that you include PT. With that, I have seen personally great results for people who have done prehab, and then after surgery they seem like they do a little bit better too. So when you talk about post-op, your post-op protocol and procedure, what are your kind of your thoughts within that first few weeks? What's that conversation that you have with that patient? It could be in that recovery room, like, where you have it obviously pre-op, but then you kind of reiterate things in that recovery room. So what do you tell your patient about the first couple of weeks?
Yeah, first couple of weeks. So a lot of that is in that preoperative visit.
Mm-hmm.
Like, what are expectations? So if I'm going into an ACL knowing from the MRI standpoint that there's no meniscal pathology, I tell them, hey, you're going to be able to put weight on this right away.
Yeah.
I have seen people off crutches within the first week walking with a normal gait pattern and kind of in their mind preparing them like, hey, that could be me, right? And so eliminating fear. Right, mm-hmm. Fear avoidance is a real term in the physical therapy world, where patients don't do something because they're afraid, even though the knee is stable and safe for them to do that movement. And I think establishing that mindset and expectation early on, I think, goes a long way. Uniformly, I think even with meniscal repair, my goals are to have people putting full weight bearing and having minimal restrictions by 4 weeks, if not sooner. And going back to that conversation about personalization, I think every meniscus tear is unique. And so based off of that meniscus tear, I communicate directly with the physical therapist how long I think they need to be protected. Yeah. So there's some meniscus tears I fixed. I don't have to restrict their weight bearing. Others, I'm like, okay, maybe just a couple weeks. And others, I'm like, okay, we have to be a little bit more protective based on the integrity of that repair and the strength that's required to hold that meniscus together.
Yeah, no, that's awesome. What is kind of your? I know it seems like from one personal experience working with you a little bit, but then also just generally your philosophy when it comes down to rehab after your ACL surgeries. How soon do you get your patients started?
Yeah, so everyone starts post-operative day one.
Okay.
And that means you have surgery one day, you are in physical therapy the next day. There are some rare exceptions, holidays, etc., scheduling, but in general, everyone gets in the next day. That's why I set my OR days to be Tuesdays and Thursdays. I try not to operate on Fridays for that same reason, to make it more practical for people to get in the next day. Multiple reasons for that. One of them I had mentioned a little bit earlier is the regional nerve block. So that typically works for 24 hours or more. So that first visit for a lot of patients can be under the influence of that nerve block, which means that they're not having pain. They can range or move the extremity without significant pain limitation. And that does two things. One, it triggers the body that, like my knee can move, but whether that's more of a psychological thing or it's a physical thing, that sets up the progression of rehab and movement much faster. Secondly, I think there's a huge psychological component of, okay, I just had the surgery. If I'm just going to sit at home and do nothing for that first 24 hours, it builds a little bit of doubt, a little bit of uncertainty. Whereas if you're there the next day, you're taking the bandages off, you're seeing what happened, you're saying, okay, my knee looks just like it did before surgery with a couple bandages, and I can move it, I can put some weight on it. You can reinforce questions and answers of like, hey, what can I do? What cannot be done? Mm-hmm. How do I go to the bathroom? How do I change? How do I do some of these simple day-to-day tasks, which maybe we didn't focus on prior to surgery because this was such a big deal. And I think that's where our physical therapy colleagues really are able to lend a hand and communicate and fill that void.
Yeah. No, I think that's great. I think it's a great philosophy. I personally have seen all types of start dates with ACL reconstruction surgery. I personally feel like the day after appointment is so important. I remember when I first got my first one, and because I was so used to seeing maybe 2 or 3 weeks out sometimes. When I got the first one, first day post-op, I was like, what are we doing here? I was like, what's going on? But I have now almost grown a little frustrated when I don't see them day one post-op because it's such a key and vital appointment, and it just sets the tone. Most likely you'll get multiple members of the family there as well too, just so you can have that full conversation and set expectations up for everyone. And again, from a psychological standpoint, I think it's so crucial and key to get going early. Just to have them see their knee move, even though they just had surgery less than 12 hours ago. So I think it's a cool thing. Obviously, expectations is so big. It's one of those things where you can do all that pre-op conversation and pre-op work and post-op. You can reiterate some of the things you mentioned pre-op. It's still a point in time because it's such a long surgery, right? Or rehab process to get back. People still have the sensation like, man, I should be back. So what's your conversation like when it comes down to like that? When someone says like, hey, when can I play football again? When can I do track again? When can I do gymnastics again? What's that conversation like for you? Obviously, there's a lot of different variants that goes into it, but from your perspective.
Yeah, absolutely. So again, a lot of that goes into that initial visit. For most individuals, I set the expectation it's going to be a minimum of 9 months prior to a full unrestricted return to sports and competition. There's some literature to show that helps reduce the risk of re-injury. I will say objectively, in my experience, I've had someone go back as early as 7 months post-operatively without restrictions, and they did really well. And that again is personalized to their injury, their rehab, and specific individual factors there. But I let them know that there's a possibility that can be done sooner. And that for me is important to be objective. So we have return to sports criteria, return to sports assessments that patients can take that helps to define, hey, the injured limb is equal to or stronger than the non-injured limb. I think that's one of the objective things that I like to look for that really gives me confidence, like, hey, you're good to go. And a lot of that really does depend on the quality of rehab, the amount of time and effort that patient is able to put in. And that is something that's very valuable to communicate and convey upfront prior to surgery.
Definitely. Yeah, no, very cool. I appreciate that, and I think that's it's a much needed conversation. We could probably talk all day about setting those expectations and doing that, but obviously it takes a kind of a team approach with that. So
Get into that part. Yeah. I mean, there's one more thing too that I was thinking about though before we get into the kind of collaboration between yourself and us as PTs. How do you ensure like consistent results between one surgery to the next? How do you go about that?
Absolutely. So consistent results for myself is really about consistent performance and execution of our steps. So a little bit going back to the surgery standpoint, right? So on the day of surgery, we try to have a very uniform team approach. Everyone prepares for the case. Everyone positions the patient the same way, and each step is done more or less the same way. We have different options on how to treat specific meniscus pathology, specific fixation of ACL grafts. Let's say that one patient's bone may be a little bit softer than another. We have different fixation techniques to make it optimized. But my goal is to leave the operating room with the utmost confidence in that procedure. And then after that is done, I think that one of the next steps, and I think you're going to segue into this, is really that communication with the physical therapist of what happened in the operating room and how that should influence perhaps that first 2, 4, 6 weeks of rehab to help appropriately progress them and get them safely to the next phase of rehab. And I think, one of the things to comment on is, patients wear a post-operative knee brace after surgery. I usually see them at the 1 week timeline, or myself or Sister Jacob, my PA, would see them at that first visit. And, they're wearing the brace about 24/7 leading up to that. But at that point, I encourage them to start to wean out of that brace, at least at night. They can sleep without the brace. They can leave it off when they're, sitting around the house and not mobile. And my goal is really to try to minimize the time that they're wearing it, because when you're wearing the knee brace, you're not necessarily activating your muscles in the same fashion as you would be without. And so within kind of a safe spectrum of management, it's better to wean out of it sooner rather than later. So my goal is between 4 to 6 weeks, just about everybody is out of the brace.
Yeah. And you mentioned teamwork too. Obviously, your teamwork between the people in your own immediate group and your immediate team. We're part of that too. When you refer patients to us and we enter into that realm, how do you what is a good partnership look like to you between physician, PA, and PT?
Yeah, I think it really comes down to trust, right?
Yeah.
Understanding that the patient's best interests are the priority for everyone.
Mm-hmm.
And I think that trust builds over time. So I think it's very easy for me to be, like, hey, I have a new ACL injury in my office, and they play X sport, or they go to certain school, or they're involved in this social circle, and I can be like, oh, like, you're going to go to Legacy, or you're going to go somewhere else.
Sure.
Because they've done it before. We've been in this situation. We've treated this specific athlete, this specific sport, and our goal, and I think a lot of us are wired the same way, is that keep trying to improve, keep trying to do things a little bit better each time. And I think when you set that standard and keep building on it, I think that's longevity, and doing it over a longer period of time, I think, means a lot.
Right. Yeah, no, I think so. I think so too. I think that's a great point. And in terms of like things that us PTs can do that you want us to focus on early, mid, late stages.
Yeah.
Let's take early. You want us to get that extension down first. You want us to get the flexion. You want us to improve gait. What is your, I guess, big ticket item that you're really looking for early on?
Absolutely. Early on, I think about range of motion and edema management as some priorities, right? So getting the mobility of the knee back, because early on is the best way to get that. So even at that first visit, I'd love for people to have full extension, probably be able to do a straight leg raise, although not everyone can do it at that first visit, which is 1 week post-operative, and then get to about 90 degrees of flexion. Yeah. And I think if you're already there at 5 to 7 days post-op, you're not going to have any issues, right? Yeah. There, and CB alluded to this earlier. Is like certain people don't even start PT for 2 or 3 weeks, and then you're working to get there, and it's much more challenging. Right. After you've mastered this range of motion and edema management, throughout that time, our goal is to be able to maintain the muscle mass that they already have, so they're not atrophying in that time frame. But then once you've maintained that muscle mass, then you can start strengthening. Yeah. Strengthening, gait training start to go together as those muscles are starting to fire in unison and kind of collaborative approach.
Great. Yeah.
Yeah, that's awesome. I think the PT patient physical therapist, like that dynamic has to be so strong. Just throughout my career working with early on, not knowing many providers and working with patients, I just noticed that there's always a disconnect maybe with how a particular person wants the rehab process to go, and but it really has delayed care. I have seen, unfortunately, a lot of physical therapists that may not have seen many of these, and there could be a fear of advancement or progression and those things as well too. So I think having a good collaborative team with providers, I think, is so key and crucial. So. Again, it's all about the patient, right? So we want to do the best thing for the patient. Just having that strong relationship is key.
Yeah.
So, awesome.
We obviously have to get this into it with the family and education of the family, because you said that there's so many young athletes that you work with as well, and talking to the parents and whoever else might be involved at the pre-op stage. If you were to have, like, I guess, what do you wish every ACL patient and their parents, if it's an athlete, what do you wish they knew before surgery? I know you focus on the timeline and all that, but if there's something in particular that you really want them to take away.
Yeah, I think it's having an understanding of the timeline, having an understanding that, as more of a colloquialism, that it takes a village, right? Yeah. It takes the surgeon, it takes the surgical team and the care team from the medical standpoint. It takes the physical therapy team, and it takes the family and the support structure around that patient to really get back to sport. Yeah. And I think of the treatment pathologies of the treat, right? I think ACL that's why we mentioned as the holy grail in the beginning, is I think it really requires all of that, and it requires it to a level that many other injuries don't necessarily match, because the stakes are sometimes so high, right? So this is somebody that is really trying to perform at a very, very high level, and to be able to get back to that or match that takes a lot of resilience, and that resilience can only be supported by having a supportive family, a supportive physical therapy team, and there's ups and downs. I personally have had both of my ACLs torn, and I've been through this many times, and I understand it from that perspective as well.
Yeah, and that trust, I mean, is huge, obviously, too, right? And I think if patients, and we've had plenty of opportunities to be fortunate enough to treat people that you've operated on, so thank you for that. But I think that they really see, especially the parents and the patient, but when they see that we know you, or that we, would text you immediately and we get a response from you immediately, I think that trust is strengthened, and that's a really big kind of comfort for these patients? Because a lot of times they feel super anxious, they feel really discouraged, they're scared, they're whatever it may be. So I think knowing that trust is there, and the I guess just teamwork is
Vital,
right? Exactly. So that's important. What would be your message to those patients that are super anxious or scared or discouraged when they realize, oh man, this is a 9 month to a year to who knows, even longer? What would you say to them?
What I'd like to focus on is the positives, right? We talk about this 9 months to a year of return to sport, but what we really don't realize is they can be running in 2 or 3 months. They can be participating in their sport-specific drills, whether they're on the ice as hockey players or they're kicking a soccer ball, they're shooting hoops. 3 to 4 months, right? 6 months, they could be doing all kinds of non-contact drills and things that really make them feel like they're back to doing what they want to do, but it's in a controlled environment. And I think that that's really, really valuable, where having a team that understands their sport and what they need to do, and introducing some of those elements early on so that, they don't feel like their skill set is getting rusty or they're losing some of that hand-eye coordination. And I think that goes a long way, because you give them a little taste of what they want to do, and they're like, good. They're like, okay, that's fine. I don't need to be able to compete on Fridays or Saturdays or Sundays yet. I just need to be able to go and practice and do what I need to do in a safe environment. And that comes much earlier than that 9 month timeline.
Yeah, absolutely.
No, for sure. And I was hoping you brought up your own experience, right? I think it's super powerful to have that. Do you ever have that conversation with those patients that are kind of going through this long rehab process, and I'm sure that can help draw some relatability for you?
I think it can be really a strong point to relate to the patient and kind of personally connect and help empathize with what they're going through. From my personal standpoint, I tore my first ACL when I was a second year medical student playing soccer. It was a contact injury, so I had a patellar tendon reconstruction on my right knee. I tore my contralateral left knee as a resident, so about 3 years later playing basketball. That was reconstructed as a patellar tendon as well. At that time, I didn't understand the elements of rehab and physical therapy. And so I went back after a certain amount of time without passing any return to sport tests or having time to rehab appropriately, and I re-injured myself. I had a secondary ACL tear. And at that point, I'm a second year resident. I'm like, okay, what do I do? I'm ACL deficient now again. I'm learning about orthopedics. And I'll be honest with you, as a resident, you really don't have the grasp or understanding of how to make those decisions. So my next decision was actually get an allograft reconstruction. I was like, I don't want to take any more of my own graft. I've already lost it on the one side. I've lost my patellar tendon. That allograft lasted me for another 2-3 years. and when I was a fellow, so about 3 years later, I played some flag football and I did some things in between. Things didn't feel quite right. Went back, got another MRI, there was nothing there. So graft resorption is one of the most common modes of failure of an allograft. And so I think maybe that's my personal, vendetta against Allografts. I use it, but and so ultimately, one of my closest mentors, Dr. David Alchek, did my left knee with a revision for the quad tendon. So I've had patellar tendon, I've had quad tendon, I've had Allograft, I haven't had any hamstring reconstruction. So at least I can relate and understand the rehab. And I think from a psychological standpoint, I spent 8 to 9 years of my life rehabbing ACLs. So it's significant. And I think being able to connect with people and share that understanding, and also maybe showing them what ignites my passion for this injury and treatment is really important.
No, I think that's, again, super powerful that you have that you had that experience, and obviously from the mental side of things, you can see how that can be really taxing as well too. But it probably helps propel you and your motivation to continue to look forward to the future with this, right? And to see how we can find ways to make things more innovative and different techniques that can make this more effective and hopefully avoiding those re-tears that do come along with this procedure. Are there any current trends or changes that you see in the ACL, surgery process and everything now?
Yeah, I would say the biggest one right now is lateral extraarticular tendinosis. This is an augmentation procedure. So everyone has an iliotibial or IT band that travels down the outside or lateral aspect of the leg that attaches to the knee. What we found is that we can borrow a strip of that IT band, So reroute that around the lateral collateral ligament, which is the ligament on the side of the knee that gives side-to-side stability, and anchor it to the femur. As we had talked about earlier, the ACL provides rotational and front-to-back stability of the knee. This augments rotational stability. So we can get into the mechanics and the physics of it, but effectively, if you're taking one strand and you're trying to fix both rotational and front-to-back stability, it may not be as good as two strands. Right. And so that's kind of the focus on it. When I was a fellow, I did some extensive research into the consequences on that procedure and how it might affect the lateral compartment or how it may have negative consequences. And we found that it had none. It actually did not negatively impact people. And then in the last couple of years, there's some literature, especially strong literature coming out of Europe, where some of those athletes are almost 100% of them are getting a lateral extra-articular augmentation, and the risk of failure is lower.
Okay.
Where I have, our indications right now are that it's indicated for people that are high risk. So that's kind of a broad topic. So usually people under the age of 25, but more importantly, those that have increased ligamentous instability. So there's something called the Baton scale where we can look at how mobile they are. So some people can hyperextend their elbow. They're really flexible as it comes in. Those people are higher risk of ACL tears and subsequent re-tears. That's a really good population to be mindful of that. Female sex, we know that females have a slightly higher risk of ACL injury than males. That has to do with their Q angle, which is the angle that comes from the hips to the knees that puts more stress through that part of the knee. And then, there's just some more minor things, whether it's looking at their anatomy, whether it's the slope of their tibia, whether there's an initial injury of the MRI suggests that there's an injury on the lateral side of the knee in addition to the ACL. These are some subtleties that we're still figuring out, but those characteristics give us some mindset of, okay, does this person need an ACL reconstruction alone, or do they need that plus this augmentated procedure on the side of the knee, which is called the LET, or lateral extra-articular tenodesis. This is something I've been doing more and more in some primary cases, revision cases, meaning patients that have had a prior ACL injury. I've almost done exclusively that plus the revision ACL. And so far I found it to be promising.
Sure.
And so that's, I think, still something we're learning about, but it's a powerful technique that I've started having more and more conversations with patients about. And I think, to me, it comes down to this clinical judgment of, as we had talked about earlier, people are built different. So you get into the OR and somebody's really unstable, you're like, well, okay, maybe they need something extra. Whereas there is people that have a torn ACL and you examine their knee and you can't even tell that it's torn. They're just so solidly built. Those people I'd be less likely to maybe consider an augmentation procedure, but this is exciting because we're continually trying to improve and build on our techniques.
Yeah, of course, great. Do you feel like that's gonna shorten timelines at all or anything like that, or what's kind of that little bit?
Yeah, so I was thinking about this past weekend. I think one of the challenges we face is inevitably for people to go back safely, we want them to pass their return to sports assessment. I think this gives a little bit more confidence of reducing re-injury risk. So I think we may feel more confident pushing them in certain ways earlier in their rehab process and potentially get them to that return to sports assessment, passing score, so to speak, before that 9-month timeline and have more confidence sending them back. So I think there is a possibility. I don't know how much sooner because, one of the things I always talk to patients about is something known as remodeling. I referenced that a little earlier, is the graft that we're putting in, it has to heal. And then it has to go through this remodeling process where the forces that are subjected to that knee become more normalized, meaning that you have this graft that really integrates, becomes their own native tissue, and that takes time.
Sure.
That takes time and rehab and demand, and we understand that happens after 6 months at a minimum. And so maybe 6 months could be the new ACL return timeline, but I don't see it being any sooner than that.
Yeah. No, I mean, it's a good point, and I think it just need to be said and fully heard. And like you mentioned, a lot of people early on, they realize hey, I can run much earlier than they said I can get back to my sport. There tends to be a disconnect when it comes down to that. I know this topic is about reconstruction, and there seems to be a lot of talk about different other type of procedures within ACL too, like a repair, which is interesting, and then restoration. There's this bridge enhanced restoration technique. If you could talk about that, I think a lot of people may not have heard about that yet. So ACL repair is a really kind of popular and hot topic nowadays. What we had talked about earlier was that we think about the ACL as a rope that shreds when it tears. Well, there are some types of ACL tears where
the ACL, which is the ligament that connects bone to bone, just pulls off the bone. So the ligament's kind of sitting there, but it's detached from the bone. That's the minority of injuries, but in those scenarios we found is that we can actually put stitches in that bone, put stitches in that tendon and reconnect it to the bone. That would be the ACL repair. And in the right subset, the right patient, personalized, it can do really well. I have done, I'd say 10 to 15 of those in my career, so not a lot, but I have seen it be successful. The BEAR procedure, or Bridge Enhanced ACL Repair, is a modification of that technique where effectively a graft scaffold. So a scaffold, in other words, is kind of an implant that's put into the knee that is ripe for growth of ACL tissue. And effectively, we can put that in addition to this repair and stimulate healing of the native ACL. This has been around for, I want to say, about 5 to 7 years. It's becoming more and more popular from, adaptation standpoint. I personally have not used it yet. I feel like some of our current ACL techniques have 40 to 50 years of data behind them, and I'd like to stand behind that. But I can say I'd be open to trying it if the right patient comes to the door and requests it. But I feel like that's still a little bit in the newer phase, and it's still being optimized at this time.
Yeah, no, very cool. So it sounds like a lot of exciting things coming up, for things. And, obviously the ACL can be a long process, but also it has a lot of rewards at the end of the day. What would you say gives you the most satisfaction when your athletes are kind of getting back to the sport? Yeah,
I think it goes back to how onerous this whole process is. We talked about how it takes a village, how it takes so much planning, and it is a little bit delayed gratification, right? You can say like, oh, you're doing great for 3 months, you're doing great for 6 months. Like the reality is, like, until they're back on that field, that court, that competitive environment, doing what they want to do. And I know we keep referencing athletes, but it could just be the gym or day-to-day life until they're successful and they've been doing it for a period of time where they, forget about that they ever had an injury. Yeah. That's our ultimate goal. And I think because it takes so much effort and so much focus and commitment to get them there, I think it is really, really quite satisfying once they're finally there. And for me, that's motivates me for every day in what I do.
It's awesome. So if there's one thing a patient could take away when they enter surgery, what do you kind of want them to have in their mind? Like one idea, what would you say?
Trust the process, right? I think really understanding that the real growth and progress happens when they're alone or when they're at home, not when they're in PT or when they're in the doctor's office. Yeah. Right? They got to put in the time.
Yeah. Absolutely.
Love that.
Yeah.
Yeah, definitely. Yeah. Well, no, I think this has been extremely helpful. It wouldn't be your legacy podcast without talking about legacy at all. And so, legacy is something that obviously is just a word, but it's much more than that, right? When you think about something that came across my path maybe 10 years ago, someone asked me, like, how do you want to be remembered at your funeral? Like, what do you want people to say about you? And I thought it was just such an interesting question. And well, a lot of people think about material things. They don't really talk about that at a funeral, right? They don't talk about someone's house or someone's car or things like that. They talk about how they were impacted and how someone made them feel and how that continues to live on with them. And so obviously as a healthcare provider, you already have a passion to help other people and, restore their lives so they can have and live their legacies, right? So I think it's such a cool thing. So what does the word legacy mean to you? And if you can kind of talk about that and, someone that you felt like left a legacy for you and that you want to leave a legacy for. So you can kind of jump into other questions. Yeah.
I think of legacy as a contribution that transcends time, right? It's something that you do that isn't just relevant in that specific moment, but continues to be relevant and maybe gains relevance over time. And to me, I'm in a very fortunate situation. The path I chose from this career, orthopedics, being a physician, it allows me to treat people, see them improve, see them kind of continue to live their lives and sometimes take care of their next generation, their grandkids, and really, see this progression of their family. And I think that in a way is a legacy of itself, right? A lot of the patients that I see in the office now are referred by other individuals they know, whether they're in their community, they're in their family. And to me, that's very, humbling and gratifying to know that the legacy that I'm leaving is being able to not only address somebody at a specific time, at a time of need, but then really setting them up for success for many years to come in their life. So I think that's just a very natural kind of outcomes-driven kind of perspective on our career.
So cool, man. I love that. I know early on in the conversation when you talk about your intro and your upbringing, you mentioned someone like your dad, right?
Yeah.
And talk about maybe the impact that had on you and kind of how you continue to want to live some of his legacy too.
Absolutely, yeah. My dad was and is quite a motivation. He works very, very hard and continues to do so to this day. And really, in his life, like medicine and healthcare and providing for others is really the priority. And he does it really with an excellent, skill set as well as passion. And that's something that I've tried to replicate and continue to find satisfaction in my life from. So, his legacy is one that I follow. I have a number of mentors that have really helped build my clinical approach and treatment, in every phase of orthopedics and sports medicine, and those are some big shoes to fill. But I'm definitely trying to do the best that I can.
Yeah. Well, that's awesome. That's very cool.
Yeah, I think that about wraps it up. So before we get to the conclusion and everything, though, we have the question of the day that we have to get to. So what is the primary function of the ACL? And this is kind of a very rudimentary answer, but the answer is to prevent anterior translation of the tibia relative to the femur. So obviously more that goes into it, and we discussed that, but yeah, so that's your answer. I think it was great. It was great. We're very thankful of you for coming on, and we think that not only ourselves as PTs, other PTs, obviously patients in the future, and maybe other physicians could maybe learn something from this as well. And we'll get it out as much as we can and try and reach as many people. And I think it's important that everyone knows that it's not just the physician, not just the PT. It's a big collaborative effort that everyone on the team needs to kind of help and rehab our patients. So
all right, appreciate it.
Thank you.
Thank you, guys.
Yeah, thanks for listening to the Live Your Legacy podcast, brought to you by Legacy PT and Wellness, and we're looking forward to do a few more episodes in the future and possibly have Dr. Ahsan on at some point too. So thank you.
Thanks for listening to this episode of Live Your Legacy podcast, brought to you by Legacy Physical Therapy and Wellness. If this episode helped you in any way, if you found it informational or educational, please share it with someone who would appreciate it. Don't forget to leave a comment or review or follow us on our socials. Links are in the show notes. Until next time, remember to live your legacy.